Okay, welcome to the Death Tolls and Blind Spots Peer Ethics Discussion panel. And it is not a panel as much as just an open discussion. My name is Drake Eubank. I also go by Robert Drake on Facebook without my last name. I'm from Eugene. I'm helping facilitate this for the OCSC, Oregon State Consumer Survival Council. Anything else? I'm going to ask for assist from other cohorts and accomplices here at different times, but what you see on your screen is kind of the parameters of how the discussion is going to go. I'm going to read a little bit from Darby Penny's article for Mad in America that talks about who decides what is peer support, and then talk about the foundational values, how this whole thing started and how it's evolved. The next will be asking people for any of their personal stories and how they've interacted with the system and where they think things might have gotten compromised, or even places where it hasn't been compromised that they appreciate. The next, I'm going to try to go into some of the reasons that there's a cause for concern, as to how many of our peers aren't treated well in the system, or essentially are served by agencies that are practicing a model that doesn't always provide for a peer to be helpful as much as what I would term an extension of clinical practice. So after that, we'll open the whole thing up to discussion and what contributes to the problem and the general corruptions of peer services and activities in relationship to the systems that pay them. And then last, we'll try to work towards upgrading how it works and how to get things righted, basically obtaining our own identity back from a system that's kind of defining the role for us at this point. So there's a lot of assumptions and conclusions in what I just said, and you're welcome to take issue with those in the course of the discussion. There are no unwelcome opinions. So please feel free to comment. And if you have something that you think you can add that's not particularly within these guidelines here, please feel free to see if it fits. So play on words, Kevin. All right. If you have a raised your hand feature, everybody doesn't have that. So if you could put it in the chat, if you want to speak, if you can't get in easily in an easy place. We've got so many people, though, it looks like we're going to end up with a traffic jam and trying to get people to speak. So I'll try to keep it as fair and as orderly as possible, but use the chat and we'll try to keep a stack.
And it looks like Kevin had his hand raised.
Great. Can you, Jessica, is it okay if you watch this stuff so that you can kind of keep track of it? Because I'm not going to be able to do both jobs at once.
Of course. Kevin, did you want to chime in?
No, I was just showing it as a demonstration that I was able to raise my hand. I think somebody said early on that that's not possible, but it is. So I was just testing. Thanks.
Okay.
I've noticed it might change if you have a Zoom account for some people. And it works on the telephone.
Okay, Drake, I think we're good now. Go ahead and move forward.
All righty. I'm going to read a little piece. Please take patience as I get through this, but it's one of the most direct and useful things I found around sort of what's happened to the peer genre since its first inceptions back in the 70s and 80s. A peer is an equal, someone whom one shares demographic or social similarities. Support expresses the kind of deeply felt empathy, encouragement, and assistance that people with shared experiences can offer one another within reciprocal relationships. In preparing a literature review on this topic, preparing a literature review on this topic is complicated by the fact that there's no standard definition. Terms like peer support, peer delivered services, consumer services, peer specialists, peer workers are used interchangeably in literature, making it difficult to draw a meaningful distinction amongst practices that are usually fundamentally different. To make sense of this, I being Darby Penny, sorry, created two categories to differentiate the terms that were conflated in the research literature. One I called peer-developed peer support, which is essentially peer support developed by the movement, and the other called the peer staff model. Definitions of the two categories are offered below, and I find these definitions really helpful. And I'll skip the next paragraph. She does draw the conclusion that psychiatric survivors' experiential knowledge has been co-opted by the system, and asks the question, what can we do about this? Peer-developed peer support. Peer-developed peer support is a non-hierarchical approach with origins in informal self-help and consciousness-raising groups organized in the 1970s by people in the ex-patients movement. It arose in reaction to negative experiences with the mental health treatment and dissatisfaction with the limits of the mental health patient role. Peer support among people with psychiatric histories is closely intertwined with experiences of powerlessness within the mental health system and with activism promoting human rights and alternatives to the medical model. Peer support was influenced by the human and civil rights movements of African Americans, women, and lesbian and gay men in the 1960s and 70s, and by the independent living movement of people with physical, sensory, and cognitive disabilities. The independent living movement sees disability as the result of physical, attitudinal, and social barriers, rather than the consequences of deficits within individuals with impairments. While peer support has political roots, it also is an interpersonal process with the goal of promoting healing and the growth in the context of community. That's the peer support, developed peer support model. And it's not a model, excuse me. The peer staff model. The growth of peer staff model is illustrated by the recent rapid expansion, and this was written a couple of years ago, rapid expansion in the US of peer specialists and similar positions in mental health programs. While there is no standard definition, many states, provider organizations, and government agencies have developed peer specialist or similar job titles such as peer mentors, peer support specialists, recovery support specialists, and recovery coaches. These job titles apply to employees with psychiatric histories who work in paraprofessional roles in traditional mental health programs. Peer workers in the traditional programs generally do not offer peer support, quote unquote, but provide clinical, ancillary, and/or paraprofessional services that are almost indistinguishable from those provided by non-peer staff. While peer staff may be providing clinical services, they do not have pay equity with the actual clinical staff. Relationships between peer staff and service users are usually hierarchical as opposed to the horizontal relationships of peer-developed peer support. And these workers are seldom exposed to the principles and practice of peer-developed peer support. Now, the next page or so, the end, is about how this process morphed in the peer support model, peer support itself morphed into the peer specialist role. Grassroots peer support practices were developed out of necessity by psychiatric survivors. These were then adapted by bureaucrats who do not understand the principles and values of peer support and modified the idea to create peer staff positions. This is an instructive case study of the co-optation of psychiatric survivors' experiential knowledge to benefit the system, while leaving intact the system's coercive structure based upon depriving people of liberty and occasionally forced treatment. In the 1970s, peer support was informal and unstructured. People met in private homes, church basements, and libraries, but rarely in spaces affiliated with the mental health system. During the 80s and 90s, independent peer-run nonprofit organizations emerged, and many of these were supported by government funding and began to offer more structured peer support. With funding came oversight, and soon state mental health authorities define what was meant by peer support in their funding contracts, usually without consulting the peer support experts. During the 90s, state mental health authorities began creating jobs in traditional programs with titles like peer specialist. And while these jobs are designed to be filled by people with psychiatric histories, they do not generally provide peer support according to the definition of peer-developed peer support. These staff are often supervised by non-peers, that is, people who are not psychiatric survivors and do not share the staff's experiential knowledge. So in 1993, New York became the first state to establish a peer specialist service title. The position was developed primarily by policymaking staff with psychiatric histories, motivated by the desire to bring the values and principles of grassroots peer support into paid staff roles. However, and this is the important however, and probably is the crux of what the discussion is in this session we're having now. This is not what happened in practice. Peer specialists' ability to adhere to peer support values was compromised by the clinical environment and those who did not understand the principles involved, including many who actively worked to undermine them. This is Darby Penny speaking. I played an active part in this initiative, a role that I now regret. The expansion of the peer staff model accelerated when the Centers for Medicaid and Medicare Services issued a directive in 2007, clarifying the conditions under which peer services could be reimbursed by Medicaid. The policy letter spurred an increase in peer specialist service paid for with Medicaid funding and conflated peer support with the peer staff model, implying that any service provided by a qualified peer support provider was, by definition, peer support. The directive defined peer support services as an evidence-based mental health model of care, which consists of qualified peer providers who assist individuals in their recovery from mental illness and substance use disorders. From CMS. How they arrived at this is at this curious definition. The research literature affects this confusing and circular characterization. Definitions of peer support used in recent major review articles include direct service by a person with serious mental illness to a person with a serious mental disorder, past or present consumers of mental health services employed as providers of mental health care services, peers providing ancillary or clinical mental health services and traditional programs, services provided by a consumer of mental health services, and the use of consumers as providers of services and supports. And it's almost done here. So the expansion of the peer staff model led to peer specialist certification programs in 41 states. I think that's increased at this point since this article was written, most of which require a completion of a state-approved training course using a state-designed curriculum or one of several proprietary training programs, which in the state of Oregon are programs that are certified by the Traditional Healthcare Workers Commission. There's no guarantee that these courses are designed by people with experiential knowledge of the mental health system or of peer support. These trainings vary in length, intensity, and content, but they generally do not include the training on the values and principles of peer-developed peer support. And this discussion is basically to kind of add up the damages of that divergence from the values of what peer support was originally meant to be to what it's sort of becoming over time as more and more people are matriculated under clinical supervision and are practicing what are peer skills that are certified by the state, but not really adequate to reflect the original values that made it an important service and important support. So, and with that, I would like to sort of open the floor to other folks here to comment on what they think the original values that they got into this consist of. Mike would be a great person. Kevin, all these people were around when all these things were fledgling ideas. And I think they probably have as much experience as anybody I know around how things got to be the way they are and how they started out. So.
Michael has his hand up.
Yes, I became involved in what was called at the time the CSX movement, Consumer Survivor Ex-Patient Movement. I consider myself a psychiatric survivor. And at the time, we provided direct peer-to-peer support as a developed by peers model. We were funded by the state. The oversight was extremely minimal within our socialization program, that is. We also had 3 case management teams. I was the first president of the board of Mind Empowered, and in conferences with peers, in talking with peers, I really learned and understood peer values. And our evolution really began in state hospitals where people supported each other. One of the first organizations around this was WANA, We Are Not Alone, which was established by ex-patients of Rockwell Hospital in New York. The values are dramatically different, that the values that we, the psychiatric survivors, created are dramatically different than the values imposed upon us in the workplace if we're hired by an agency that is not a peer-run organization. I'm fortunate enough to be the executive director of a peer-run organization. Even so, we have peers who must work within the confines of the rules, regulations, and desires, for lack of a better word, of other agencies, since we have contracts with those agencies to provide peer support within them. The splintering off is very, very well stated by Darby Penny when she says that we had peer-developed peer support that was migrated into peer support as defined by governmental entities and other entities that did not understand our values. I'm incredibly, incredibly grateful for this particular workshop, for lack of a better word, discussion, for the simple reason that in our own conferences, I've seen many people say, well, I was providing services to one of my peers and clinospeak, taken from the medical model or the clinical model, for what once was, I was helping this friend work through these issues, and he was helping me work through these issues, and we walked together and really figured things out. I would love to see a radical return to our roots. And the only way that that can happen is to get the word out about what our history is, what it looked like, and what the outcomes were. We came from those roots. Anybody who calls themselves a peer supporter, peer support specialist, recovery mentor on down the line would do well to understand where we came from and where we can return to. I'm not in any way suggesting that we lift services that are provided by peers from entities that are not peer run. I think that has a valuable component. Danita Diamata, who I worked with at Renaissance within a large mental health agency in Portland, she and I operated a drop-in center that had about 130 people a day come in. And we influenced dramatically the way that services were provided by clinicians within Cascadia, that agency. We did not change our values. We operated the same way we always had when we were at Mind Empowered before that, working together. And there are ways to influence the system towards systemic change in that manner. All that being said, it is still critically important that we educate up-and-coming peers on our history, on the value of that history, and what peer values are, and what walking together means. I appreciate the time.
Thank you, Michael.
Let me direct it real quick to the chat. I saw Andrew had a question, and then we also have a couple hands up as well. Andrew asked, what are your thoughts on intentional peer support and how it represents peer-developed peer support?
Is that question directed towards me?
I think it's for the group, but Andrew, correct me if I'm wrong.
Really to anyone that it resonates to.
Folk Time operates the Oregon hub of IPS, and the training is very peer-centric. It was developed by peers for peers. And so I strongly espouse that particular means of providing services. It mirrors to a great degree what we were all about all along in our early years. It simply codifies it in a way that's discernible to people who haven't been introduced to our history. And that's not without exception. There are some exceptions, but I very much love the IPS model.
Okay. Oh, did you
A
have
doc-
something to say?
A document came referenced in the chat, Malcolm Aquinas. Is that someplace around or available?
So yeah, I mean, I put the document in the chat, so that is the document. So somebody I sent the document in.
I'm sorry, I stuck
a long entry, and then I put a note that was referencing it.
Great, sorry.
The PDF. No, it's okay.
I have
And
it.
so since I jumped in, I will say that although, I mean, I have no financial ties in any way to intentional peer support, I will say that intentional peer support is the only peer support training in the state of Oregon that I would use the term training for. Not that the other ones aren't valuable, but they are a series of presentations. IPS digs down, does a lot of experiential activities for people. They have opportunities for people to get feedback. It is more of what we would consider a training, which is you can expect people to know certain things by the time they're done, as opposed to presentations where you can hope that people find what you've said interesting and maybe they'll follow up on it later.
Okay, I see people with some hands up. Let's go first to Roberto.
Hi, my name is Roberto. So after hearing what Robert read in that literature that was there, I'm under the impression, maybe Robert could correct me, that these courses that they have for training for peer support and CRM2 are pretty much not put together by, they're just put together by, you know, peers, right? And who have been in recovery and stuff. But like the mental health branch isn't fully there, right? So my question is, are there courses that mental health experts and peers have come together to put together a type of training to help those with severe mental illness as a peer? You guys understand what I'm trying to say? Like, I'm gonna be honest with you guys. I'm gonna be frank. I'm in recovery from meth and alcohol. I like working with people who have that that problem, right? But when it comes to severe mental health, I still feel that I'm not qualified after so many trauma-informed trainings and stuff that I've done. I still feel that I'm not qualified to work with that person with a severe cognitive issue. So my question is, are there those type of trainings? You understand what I'm saying? Where mental health professionals have said, okay, if you want to start being a peer to mental health people with cognitive issues, here's how you can work with them. And you understand what I mean? Are there those types?
Yeah. So annoyed. Because I called him and then he was like, hey, as he's
Can I just follow up with what Roberto was saying? I completely understand what you're saying regarding dedicated peer specialist training. I would love to hear more about HIV folks, because that's who I deal with. I completely hear what you're saying about I'm not well prepared for dealing with mental health issues, but I am a peer and some of my clients are that. But for me, it's the same thing, mostly drug addiction. It would be great to be able to have those specific dedicated training set up for intentional peer services. Yeah, thank you for bringing that up.
my name is my name is Patty, and I'm a peer support with Yamhill County. We have a lot of elderly people that are coming in, and a lot of people that have TBIs, traumatic brain injuries, and whatnot, I think it would be really helpful for people that have more training on that and more stuff centered around how we can help the other population, not just drug. I mean, you can get a TBI from all kinds of different things, you know, strokes and everything else, which is also could be drug related. So I think it would be really helpful to have some experience with that. And we find over here that with the DD services here, that it's really hard if they have mental health or drug addiction that they don't want to address the DD part of it. And so they all come to our area. It's that, you know, yeah, they have mental health and yeah, they have developmental disabilities, but it can all be treated in one place instead of in both because they're not trained for the other issues also. And we aren't for the DD or for the TBIs or Alzheimer or any of those.
Couple folks with their hands up.
Yeah, thank you, Patty. I see we have Jim and then Ray. So thanks for waiting patiently. Go ahead, Jim.
Hi, everyone. First, I want to just echo the sentiments regarding IPS. Some years back, I had the opportunity to take that training at a point in my career where it virtually rejuvenated me because I was burned out and ready to throw in the towel. And I'll go into that a little bit more in a sec. But I broke into peer supporting, I guess, on a paid level in 2015 in another state. I was in Oklahoma. And I went to work for a community mental health center. And the agency was quite large and it's grown larger since. And in a way it was good. I didn't really, you know, I kind of learned as I went. I took the training there in Oklahoma and they have excellent training for peer supporters. It's not the state itself, it's just the agency I was at. And, but at that agency, it was very much hierarchical, both in terms of how we were expected to provide peer support to peers. And in the agency itself, it was hierarchical in the sense that we were supervised by clinicians who had really no clue of what we were doing or supposed to do. And we had clinicians writing policies, procedures, and guidelines for peer support. And regarding the peers themselves, it was very coercive in the agency. We were directed to talk them into staying on a medication they didn't want to be on or something like that. It just really did not sit well with me. And I was there for like 5 years until last year. And quite frankly, it ate my spirit. And like I said, fortunately, I was able to take the IPS training and that kind of kept me going. But I'm just really grateful that I'm able to be where I'm at now in a peer-ran organization. For those of you who, I don't know, we have it pretty good here, considering how it is and where I was. I just wanted to put a blurb in for really, I mean, there's things wrong with it. There's flaws. You know, we still have state guidelines and regulations we have to work within, but we really have it pretty good here in the area that we're in. So I just wanted to put in that positive blurb.
Thanks, Jim. Now we have Ray. I hope I said that right.
Hi, it's Rhea. Thank you so much. I'm really interested in this discussion, and I appreciate the opportunity to speak to it a little bit. I'm fairly new in the peer support world. I'm a peer wellness specialist. I'm just under a year, and I'm working for one of the largest behavioral health organizations in Portland. And I was attracted to becoming a peer support person because of my own experiences. I'm a psychiatric survivor, and what I realized at one point is that I've been to hospitals, intensive outpatient treatment, in therapy, psychiatrists, like my whole life, pretty much. And I realized at one point, like, being a part of like DBSA groups and even at intensive outpatient treatment and even in hospitals, I was like learning these skills, DBT, coping skills, whatever. Like, it's been helpful, certainly. But the thing that I got the most out of all of my times in those places was talking to other people like me. And so that's what led me to like want to become a peer support person. And it is very interesting being in something that is like a grassroots, which comes from us and has now become professionalized. And I appreciate that we're trying to talk about the ethics of that, and wanting to preserve the values of peer developed peer support, even while we find ourselves navigating in these uncomfortable spaces. Because I certainly feel uncomfortable a lot of times, feeling like I'm a part of, a large mental health system that I internally vehemently disagree with on a daily basis. Well, a couple of things that I want to bring up that I'd be interested to hear people's thoughts on. One is mutuality. Oh, and I also want to say that I feel like the training that I did at MHAAO really did go into the history and really did talk a lot about the peer values. I appreciated the training that I got there. One of those peer values is mutuality. And I feel like there's a very interesting, it's confusing, I think, when you are being hired to perform a job that has as a value attached to it as a peer support person, mutuality. I think that there's sometimes an expectation that we can even put on ourselves, where it's like, well, I'm here for that person. So that even if I'm sharing my story, like, I want to be careful about like letting this peer know that I'm working with, hey, I'm actually in like a major depressive slump and have been, fantasizing about self-harm and suicidality again. Because like all of a sudden I'm in this role where it's like, I'm the one that's supposed to be helping this person. And so mutuality kind of is a really hard line to navigate sometimes, even though I believe in that as a core peer value. We can get caught up, I think, in like the caregiver role, taking on that role and feel like, oh, well, I shouldn't really lean on this peer who's in a mental health crisis right now by telling them stuff that I'm going through. But that's part of the beauty of peer delivered services, is the mutuality. So that's one thing that I'm interested in. I also want to speak to staff. First of all, non-peer staff having no training about what peer staff do, who they are, where they come from. That's a huge gap. My supervisors kind of had no real idea of like what a peer actually was. And so a lot of my job has been trying to educate them and send trainings their way. Hey, you should do this training so you know what it's like to have a peer on your staff. And then I definitely have had instances where other staff is using me as like this soft buffer to get peers to do something, right? Whether it's like encourage them to take medication, we think they need to go to the hospital, those kinds of things. And I've had to really have clear boundaries. Like I have no opinion about whether this person should be on medication. That's their choice. Actually, I'm not going to go try and convince them into taking or not taking any particular medication, but I've definitely had that happen over and over again in my role. And the other thing about professionalizing the service is that another peer value, I think, is that it's voluntary. Nobody has to see a peer, but it's also, again, I'm in this role where I'm being paid to be on this staff. And there's an expectation then that I'm meeting with the peers. And the way that I approach that is like, I introduce myself, I let them know what I'm here for. I talk to them about it, or I check in with them every day. Hey, how's it going? You need anything? But like, I don't have the expectation that they have to meet with me. But I think sometimes there is a supervisor expectation. Hey, are you meeting with peers? I'm like, if they want to meet with me, right? I'm here for that. So that also blurs the lines a little bit too. And then the last thing that I'll say that I'm also interested in is how often I hear people who are on at a certain point in their own recovery I've seen over and over again, people are encouraging them to become peer support people or peer wellness specialists. That's what they are here in Oregon, as if that's all they can do. And I see peer support becoming this kind of like, we'll funnel all the people with mental health challenges, in recovery and substance use issues, like they need to do that job then, as though it's like it's erasing their individuality and their identity. Maybe they don't have the skills for that. Maybe they don't want to do that. Maybe they have their own passions and desires. And I see that people getting pushed into that role too, when it's like maybe not a good fit for them as individuals, other than the fact that they have lived experience with mental health issues or substance use. So those are just a few thoughts that I have, and I really appreciate this discussion. I always learn so much, especially from people who have been a part of this movement for so long, and I'm so grateful for all of your hard work and your brilliance. Thank you.
Thank you. I see 2 more hands up, Andrew Pegram and then Andrew Phelps.
Thanks. Yeah. This is bringing up so much for me, just all of these thoughts I'm having around this topic. A few questions I want to ask, but I'll try to keep it short. I wanted to bring up the topic of internalized oppression. And I feel like it's something that doesn't really get addressed in peer support in general, that when peer support gets co-opted by the traditional psychiatric model, um, oftentimes we also get peers who felt they benefited from that model and can inadvertently reinforce it because they feel it helped them, so it must help other people. I know it's not always conscious and not necessarily saying that it's something people intentionally go out to do, but I think it's a bias that we can sometimes get from our internalized oppression. So I just wanted to open space for that discussion.
Thank you. Now we have the other Andrew.
May I speak?
You may.
Why, my goodness. I have been dealing with trauma from infancy, and it goes beyond the medical issues to the way the government tries to manage the entire nature of society. My mother was officially a founder of the Central Intelligence Agency, according to her, the way they wrote up her death legacy. But I've been fighting this since 1967. I got active in this movement in Berkeley. I helped to create it, and I've been over and over helping to create it. And many people, several people right here, have worked collaboratively with me in very important ways. And what we are trying to do is change it, as many people are saying, to make it the whole system changes the way in which we do science, so we understand madness differently. And we have a virtual table, which you can immediately check out. But that's just the start. The table is called Social Accountability Work Group, and it means the last 20 years, many of us have been trying to go all the wonderful things people are saying here and move them to a deeper empowerment in the society, and not get in the way of people the way that some of the other people trying to do that are doing. So I recommend looking at our website and talking with each of us more. And we seek for paradigm shift, and we are going to try to present on a deep change in the paradigm so that madness and the way people engage it happens differently and the system gets trained to behave better. So thank you. I could say more, but I shouldn't take up all the time. And thank you for your wonderful work.
Thank you, Andrew. I see we have Luke with their hand up.
Yes, yes. Thank you, Jessica. It's great to be here with you, with everyone. I'm very grateful that I have the opportunity to join you this year. Purepocalypse is a place where huge stuff happens. Historically, I'm glad that I'm involved with some of the discussions and workshops and stuff where we are making the change. We are part of the change. We are making it possible. I mentioned something in the chat that I felt like I needed to elaborate, and I have a feeling people will appreciate that. The peer wellness specialization training that I had at MHAO was hugely transformative. It really helped to bring a lot into my life and make sense. And
Are we just going there in order?
there's a
What do we do?
lot of attention on peer support, but not much on peer wellness specialization, you know, peer wellness support. So I want to change that. I've been contemplating this situation for a long time. The Wildflower Alliance, also known as the Western Massachusetts Recovery Learning Community, is a very successful, large community of people that's not really medical model, but they're very successful in promoting peer support, its values, and helping to coordinate in the area a large variety of very valuable services for people. So recently I made the decision I would like to form an alliance for the Northwest. I want to be a part of that. That will help to bring a lot of very big pieces into place powerfully in a way that collaborates, interacts with other regions of the United States. There's actually recovery learning communities in other parts of the world too. However, I want to make this point before I end here. I don't want to call it a recovery learning community. I wish to have a greater capacity for inclusion. I wish to call it a wellness support community. Let's make it happen. The name I would like to go with is Rowan Tree Alliance. We're in the Northwest. Let's do a tree. The rowan tree, the ash tree, has been used for healing for ages. We can do this. We are doing this. Thanks, everyone. We're part of this. Thanks for being here.
Thank you, Luke. I don't see any other hands up, but I see that the chat is pretty lively. Feel free to chime in if you're not able to get in the chat. The floor is open.
I'd love to hear if anybody has any thoughts about the peer value of mutuality and then being in a professional role. If you have your own experiences of that and challenges with that, if anybody else wants to speak to that, that would be awesome.
That's actually the next thing on the agenda, and we were already sort of getting people's stories before that, so. Anybody lost friends in the system?
Yes.
Now, when you say lost friends, like people who just said, okay, I don't want to do this peer support anymore, or people that have died. Sorry to say that.
There's any number of things.
Okay.
I'm having a friend who was given so much, so many drugs that their systems gave out to people that lost their lives due to not getting help they needed, to any number of marginalizations that resulted in them either deteriorating significantly, getting lost, or yes, dying. Are people familiar with the NASHPID study of 2007? Summarize it briefly. There was a study done for people in the public mental health system, and it was commissioned by the National Association of State Mental Health Directors. Its conclusion was that people involved in the public mental health system were dying about 25 years earlier than the normal lifespan of the average American. And that includes both before and after the 25 years for it to be an average. And as well, there was another part of a analysis of that same data that really attributed about 4 out of every 10 deaths to health complications or health issues that were directly related to the medications, diabetes, circulation problems, the problems with LDL impacts on their cholesterol at a cellular level that were particularly a result of the atypical drugs they were giving people, like Zyprexa, Risperdal, Clozaril. Anybody run into any complications with that? Anybody that had permanent damage due to the treatments that you know of? Because when you're supporting a system as a peer, they're depending on you when you're helping them and saying it's okay. The problem with that is that down the line, there's some pretty gnarly health consequences for long-term use of some of the treatments. So anyways, there is data out there about this. So, and the ironic thing was all of the new atypicals were actually invented for the most part to replace the problems they were having with Clozaril. Clozaril didn't have a really bad problem with tardive dyskinesia, but it did have a problem with the white blood cell count being lowered, like their immune system's going down. So everybody tried to reinvent the atypical that was Clozaril, and that's how we ended up with Zyprexa and Risperdal, except it messed up everybody's cell biology and other things.
I see quite a few hands up. Let's go with Lillian and then Katie.
You're muted.
Hello, can you hear me?
Yes.
Hello?
We can hear
Okay.
you. Yeah.
All right. Sorry about that. I thought I unmuted. Anyway, I'm brand new to being a quote professional peer, and I'm in my first position, and I have, I don't have some of the shared experiences with the different diagnoses and experiences that many of the peers that I'm going to be working with have, and I don't have the lived experience of addiction, and I'm wondering how I can best help them. But then as I've been listening to what's been going on in the conversation, I'd like to understand more about the internalized oppression of, my experience has been, what have been in the past over-medicated and misdiagnosed. But then once I got a good diagnosis for me and started the medical treatment and all of that has helped me, I'm not aware of some of the things that Duke has just been talking about. And I really need to understand more about this internalized depression and how I can avoid trying to push my experiential values on others.
Thank you. Katie?
I just wanted to say that's huge to say say was that the gentleman, Robert, he was talking about how to support diversity in background in alcoholism.
Hey, Katie, I can't, can you get in a little bit closer? You're kind of cutting in and out. It's kind of hard to hear. Yeah. Yeah.
Yes, you can hear me?
Yes.
Okay. I guess for me, I've been in the systems for a long time. And it took me about 6 years to get out of the system on mental health after being committed and forced and mandated and to take medications and everything else. And when I finally got out, it was almost like a relief, but then I didn't talk about anything. I didn't address it. I just kind of went on my way until I came back and started learning more about peer support and working that way. I spent the last 7 years working in criminal justice reform through mental health. And what I notice is if as a peer advocate, if we're not able to identify with what the people we're serving are going through, then it makes it really hard for them to have that mutuality, to connect with them in that way. And so I don't think there's a way to like teach someone how to understand that diversity. I think it really is something that somebody has to experience themselves to be able to walk alongside others who are experiencing that same thing. The same thing with alcohol or, addiction. Like I wouldn't be able to support someone fully in that realm because my experience really isn't in that area. My experience is with the psychiatric system and what it was like to be forced medicated and mandated in that system and to deal with psychosis over and over. And so I don't know. That's my question to, I guess, the group is what kind of training would that look like? Because I don't think anybody should have to experience that. That to be forced medicated and to go through those extreme states and then forced into a system. It's not a pretty picture. So I guess that would be my question. What kind of training would that look like? That's all I wanted to say. Thanks. That makes sense.
Thank
Thanks,
you.
Dee. I think next we have, I see at least on my list, Kevin.
Yeah, Kevin Fitz, is that who you're called on, Jessica?
That's who I'm calling, yes.
Yeah. Well, first of all, I want to say thanks for Drake for putting this together and starting this conversation. I think it's excellent. I first got started, it's a little bit later than Andrew Phelps or Michael Libacek. I got started in 1988 and 1989. Previous to that, I had come out of the United States military training, AWOL in an extreme state, and was diagnosed with what they called then severe persistent mental illness, the schizophrenia diagnosis. I got involved with what Mike was defining as the consumer survivor patient movement that was then had been picked up by the federal government and started sponsoring their yearly conferences called Alternatives. And one of the things that I remember early on having a discussion with somebody, I think it was in 91 or 92, is that we used to use me and some of the people that I associated with, the idea is that what peers were, Mike suggested it earlier, that they were friends. They didn't have keys. They didn't get to go into locked rooms, that peers were, were friends. And then we slowly saw the movement, and I should say, when I first got involved, there were people with lived experience who had the ambitions of running the whole mental health system. It wasn't that we didn't want to be, front end workers, which we were first called peer counselors, and then they redid that in 2008 or 9 in Oregon and set up peer support workers. But our ambitions, at least mine and some of the people that I connected with at a group called Mind Empowered, was we were a organization of people that were recovering from mental and emotional challenges and substance use issues, but we wanted to run our own agency. We wanted to compete with the Cascadias, the Central City Concerns, and that caused great consternation amongst the big CMHCs about how in the world would these people with these diagnoses, with these backgrounds, could be competent to run a comprehensive mental health organization that was very suspect about the long-term consequences of some of these meds on the body, what routes to self-determination look like. And I don't know whether it was a conscious thing, but the ongoing marginalization of the peer or the consumer voice to a support role attached to community mental health clinics or attached to state or county agencies just continue to roll on and roll forward. One of the biggest challenges that I have is that I really, really believe that the enlightenment and the empowerment of the individual peer worker is the most significant hope for political change for us to redress, particularly here in the Pacific Northwest and Oregon and Washington and all across the United States, what happens to the amount of public tax dollars that go to provide services for people who come through their mental health treatments like I do. Without the voice of educated, enlightened, empowered peers putting their shoulder behind political effort, we are still going to end up being used as ambassadors, flag wavers, song and dance men and women for the treatment model that has one size fits all and is beyond criticism and gives us high fives and gold stars, but does not listen to their inability to meet our needs and also what they call treatment, but I call coerced mental health care without informed consent. I really think that we need, and one of the things I like about Peerpocalypse is I'm always meeting more people who want to get involved politically. But I think without that, we are secondary players in how our public mental health and our SUD systems are set up at the access of political power. And I think that needs to change, or we're going to continue to be in the waiting pool of what happens in mental health and SUD services. So thank you.
Thank you, Kevin. I see Jim. Yes, Jim.
Hello again. So earlier I talked about some previous experience that I had, and as I said, the agency I was at was very billing driven. We had what they call huddles every morning, where a peer and a therapist and maybe a case manager and a nurse practitioner and a psychiatrist would meet, and staff whoever was on the schedule that was coming in to see the psychiatrist or the nurse practitioner. And that was the times that we were asked to talk someone into staying on their medications or what have you. And I don't know how many times I had to explain that I had to take a position of neutrality and that it was ultimately the peer's decision. And I had a peer who I had been working with for about 3 years. And he had expressed to me many times that he wanted to go off of his antipsychotics due to the side effects. He wanted to work on learning some healthy coping ways to cope with what he called his other part. That was what he called his voices. And he wanted to learn ways to do that without medication. And so when I had expressed that during one of the staffings, and that's, his side effects were to the point where, if you know anything about antipsychotics, if you're on them for a while, one of the side effects is his hands trembled so much he couldn't get a spoon to his mouth to eat. And he had uncontrollable movement of his mouth and tongue. And he was very embarrassed and shamed and humiliated by that. And he just wanted to be who he was without having to be subject to these side effects. And when I expressed that, it was like, you have to talk him into staying on those meds. And I refused to. I just flat out say, I refuse to do that. It's not in my scope of practice. And besides that, it's not ethical. And I didn't get fired for it, but I was disciplined. I was disciplined for it. So that's just some of my experience in working in that medical model. Not only is it dehumanizing to the peers, it's dehumanizing to the peer supporters as well. So I just wanted to share that.
Thank you, Jim. I see Michael.
Thank you, Jessica. I had a fairly good career working both outside and inside the system that I thought ended 4 years ago when I left the state of Oregon. I was working for the state of Oregon as the first director of the Office of Consumer Activities there. The reason I left was for medical reasons. Medical reason was too much lithium over too long a period of time when I was younger, and I needed a kidney transplant. This is true for a lot of people. For the use of lithium, other medications do other things. Choice, well-informed choice, because if it isn't well-informed, then it isn't choice. Well-informed choice is essential to have out there. For example, right now, I'm running an organization that I want to do well by, and I started escalating into a very high mood state. Now, I don't think folk time needs or wants to be run by an archangel or even a pseudo archangel. And that's what I tend to go to in an extreme state. So I am using medications when and as needed. At the same time, I believe that I would never have gotten ill had it not been for the introduction of medications under forced treatment when I was 16. So it's really essential that we find ways to help people reclaim their lives without the use of medications when they're younger and at all times. And peer support, of course, naturally, is a great vehicle towards that. And there are other alternatives as well. I'm done. How do I lower that hand? There we go.
Thank you, Michael. I see. Let's see. Katie, did you have something to say? I see you at the top of my list. Oh, I can't hear you, or we can't hear you. Katie, I think your speaker, or you're muted.
Sorry.
There you go.
Okay. My phone's really quiet for some reason, so I hope you can hear me. My question is I struggle with the court mandates of medication. And then on top of it, most people I work with are on like probation, parole. And then that's another mandate that they're mandated to take their medication as part of their probation and parole. And so I find that people who do not want to take medication for multiple reasons that we've already talked about end up sitting incarcerated until they're willing to take that injection or that medication. And I'm just curious how we can change that. I mean, hospitals can't even force medication on people. Why is it that our criminal justice department that has no psychiatrist, no degree in mental health can say you have to take this medication due to the behaviors? So I'm just curious about that and looking for feedback and how to advocate. It's a problem. And I don't know how to take off my hand. I'm sorry.
I'll lower it for you.
It won't go away.
It's okay. Thank you. I see we have Tiana.
Hello. I just kind of wanted to touch on a couple things that people have been saying. I really admire the work that people like Kevin have put forward. I don't want it to have to be that long for us that are coming in now. We should be able to take what they've done so far and come together and make bigger changes. It shouldn't have to take this long for us to get to certain places. But with that, I think we have to go back to the beginning and ask people from the ex-patient movement, what do they want moving forward? And then if that's for us to separate and offer peer support based on a certain specialty, if you will, then do that. So for example, it was really hard for me. I had criminal justice background and I was like, ooh, criminal justice background and mental health, put them together. And I worked in mental health court. And then just like Katie mentioned, I was told that my peers had to take their medication or they could go to jail. They had to do these things. And we were me and my former partner, Bill, we were put in these situations where if we didn't basically comply with what the courts were saying, we could get in trouble. And so we had this tug of war going on as far as supporting them as a peer. And so also more recently, working with one of the workshops earlier was working with parents who have their children in the welfare system and being able to support them in that. And they have the requirement, if you have not had your children taken from you, you cannot offer peer support to those individuals. And that's important. And so it was hard for me to be in that position and how that tug of war. And then also, like Drake mentioned, the medications. There's no in-depth training that I have been to that talks about the medications and the side effects. But yeah, I had a peer come to me and, like someone mentioned earlier, ask me about, how I felt about them staying on their medication. So I think there just needs to be, I look at it kind of like a web. Like we started off with the whole ex-patient thing movement and the beginning and the history, and now we've kind of branched off and we've gotten really far away from it. So either we come back to it and stick to that movement maybe, or we start talking about the different specialties in different areas that we can support people and relate to them and have that mutuality, because it can't be all of the above. Another side for me was my relation to people with incarceration was being the family member of someone incarcerated, which doesn't get talked about a lot. And so I was able to relate to some people with that. However, it's not the same as being in jail or incarcerated myself. So I just wanted to say, I feel like we need to go back to the drawing board and ask ourselves what we want moving forward and get the input of those that were on the front line in the very beginning.
Thank you. Next, I see Andrew.
Thanks. So this is a question that whoever wants to answer, Kevin and Michael, like I've heard some really great things from you about potentially maybe you could have some feedback on this, but anyone. So I'm trying to understand if there is a way forward where peers and therapists and clinicians can collaborate. Like, does it have to be an either or situation? And there are a ton of times where I get pissed off the system and the place where I work, and it's extremely unfair, and the power imbalance is just, it's unaddressed. But I still feel like there's a lot of potential for at least therapists who are open-minded, humanistic, innovative, to partner with peers too, in like a new system. Like I feel like we need to create this new paradigm that doesn't just apply to peers. I mean, really, we're going through a whole paradigm shift as a society in all areas: education, politics, environmental, with the environment, even religion. Like this is happening in all sectors of life. Mental health is just one that I think gets overlooked. So just curious about your thoughts. Like, what do you think that could look like going forward?
I was just gonna jump in here. I don't have a hand to raise up, so tell me to be quiet if I need to be, but I mean, as far as creating like a system where we collaborate, I don't know, within my organization at a community health center, we don't have a peer supervisor, and there's peer supports throughout all the different divisions, but nobody, like every supervisor that I've worked with doesn't really have a true understanding of what peer support is. And most therapists that I work with don't have any knowledge about what really true peer support is either. And a lot of times don't want to listen, or do want to listen, but don't have the time to, because they're given 70, 80 people on their caseload. But I mean, there are a lot of great people that I work with who are really supportive of the idea of just complete transformation of the system, with peer support taking the lead role in reducing the amount of actual therapists and clinicians. And I don't know, for me, I think a great start would be, really, because what I want to do within my organization is really advocate for peer supervisor position and have it paid as a supervisor, and have them have that same authority as other supervisors have, and be able to advocate within the system to address all these, inequalities and traumas that we endured. I mean, even within my community health system that I work with, that I was, I got services there. I mean, I pass and work with people who traumatized me in that institution. And, I think a lot of times the people that I work with and a lot of the clinicians and stuff don't realize that there is a lot of harm that they do, whether it's intentional or not, and that the system does. And so I think, first off, making supervision not just mandatory wherever possible or when possible, but putting it into law that, hey, you need to take steps to make this possible within the organization. I think that's a good first step, at least, within those institutions, because if we had a supervisor who was advocating for peers and their peer role and aligning with values, then a lot of the situations that I'd feel like I've actually have a voice, and that there were some vehicle to have some real change. But a lot of times I'm just put into these situations where, I have to literally fight with people. It's like, and tell them, I may be within this system, but I'm not of this system. I might have to do notes and follow goals and service objectives and all of this, but mine are going to be peer oriented. They're going to be this lofty thing that doesn't really have objectives, because one day we're going to talk about Star Trek, and if that's what they want to talk about and that's what gives them purpose and hope, and that's great, that's what we're going to do that day. And so I fight with a lot of clinicians about just like language in that. And it's like, you got to give me a prioritized objective that isn't of the medical model. You got to give me something that's of wellness, and then just fight with me. And it's like, you don't understand. I'm here, but I'm not you, and I'm not this system. It's my purpose here is to disrupt this system and change it and provide, unique services. So I don't know, that's where I think it has to start. And then of course, making it so that whoever supervisor they do, get, they don't be all like, well, you got to have a bachelor's degree, or you got to have a master's degree, and all the things that they want, a supervisor to have with these clinical experience and stuff. It's like, so yeah, I don't know, my 2 cents. I'll be quiet and let other people talk.
Thank you, Joel. I think I see Jim, is your hand up again, or did it never get lowered? And then
Either
Malcolm?
never got lowered or I did it by mistake. I'm gonna take it down.
Okay. I have Malcolm and then Michael.
I think it's a great question. It's of course a complex question with lots of parts. I'll actually go to the end of a thought, and then I'll come back to an example. If we want to have this type of truly collaborative relationship, we're going to have to get into the professional schools of social work, of nursing, of psychology, and psychiatry. They're going to have to hear people who come in who have the experience and get that training so that their minds are oriented and set a certain way before they're locked into where you have to undo all of the bad learning and then try to put in helpful learning. And to give two contrasting examples from my work experience, I had one psychiatrist who said he wished that he could clone me so that he could have me 24/7, 365 for his unit. He referred to me as the human equivalent of Ativan. I don't know if I like that very much, but I like the sentiment behind it. He was saying that I just had a way of that people who might be having difficult times tended to feel calmer after talking to me. I do think a lot of that is because I had shared experiences. You know, I know what it's like to be locked up. I know what it's like to have somebody stick needles in you against your will. I know what it's like to be locked in solitary confinement. And so they don't have to go into all of the backstory. They can just talk about the experience and feel that. A different example, though, with a different psychiatrist, I was called to a unit because somebody was in a very agitated state that included threatening behaviors, threatening physical violence. And the doctor, when he saw me, said, "Get off my unit." And I was like, well, I got called to come to the unit. And he said, "You're leaving my unit or I'll call security and they'll take you off my unit." So I left the unit. At 2 o'clock in the morning, the charge nurse called me on my work phone and said, "Would you please come to the unit? We need your support. You're a valuable person. This person is saying, if I'm not going to talk to anybody else, if Malcolm will come talk to me, I can have a conversation, but otherwise you're going to deal with this shit." And I was like, not knowing what to do because the doctor runs the show. And then when I got to work, opened up my email, the nurse manager has an email. "I understand that apparently the doctor told you you're not supposed to be on the unit. I am asking you, please ignore that." This is a nurse, and it's the nurse manager who says, "Come to my unit." So I turned to my colleagues in the peer services department, Rick and Becky, their names, and I said, "What do I do?" And they said, "Do your job, your peer support." So I went to the unit, and it did end up getting a good resolution in that moment. But I will tell you that I was called to the carpet for that by the chief medical officer, by the chief of psychiatry, and I received formal disciplinary action because I violated a direct order from the psychiatrist. And the final answer they had in the document they gave me was, we cannot operate a hospital when people choose when and when not to follow a doctor's orders. So it's complex, but it's important.
Do I go now? Okay, thank you. Yes, Malcolm, thank you so much for that. And I'm so sorry for what you went through then and undoubtedly many other things in your role. I agree with the education component. Without understanding, there can't be mutuality. With a huge power differential, there can't be mutuality. True collaboration requires that on some level at least, there be mutuality. I would love to see it be required of all people who go through social work schools of social work or are on a career path, and their degree that they're going for indicates that they're on that path to provide direct services to, or whatever, to individuals with lived experience. I would love to see at least one course. I and several friends of mine and myself have been called in to train a class here and there. And by here and there, I mean every cycle of this MSW thing that PSU has would get one 3-hour talk from 3 people who have lived experience. Not nearly enough. Grateful for the invite. We need a lot more. My wife had worked in mental health in one capacity or another, and yes, within a state hospital, and was very good at what she did. She'd worked for 15 years in that field, and some rookie, and by that I mean straight out of school, was telling her what was and what wasn't. It's vitally important that people be educated well. If we're going to have true transformation, and the system is going to still exist, that system needs to understand us. And no better way for it to understand us than to be taught by us. So actually, I'm just giving an idea to pressure PSU to require a course taught by us. Anyway, that's my 2 cents.
Thank you, Michael. Drake, are you still there? I see you've got your hand up. And Allie?
Yep, still here. Yeah, I had the great opportunity to have a peer-run clinic for a while where we actually got to hire and fire the psychiatrists and the other people that worked as clinical employees. And even with that, it was a hard row to hoe to find people that weren't so bought into their role that they didn't think that pretty much they were God as soon as they arrived. And it sort of made it the tail wagging the dog for a while. But one of the things that I remember from doing that and watching the first peer services be kind of interjected into the clinical system where I am, I'm in Eugene and Lane County, was they'd had some sessions, just staff and just peers for the system to comment on what they thought could be improved and what was kind of wrong with the other side. And one of the interesting stories that I came across in one of those sessions was one peer complained that the clinical person that he worked for in the clinic, when he saw him out in public, somehow because he had a diagnosis, he refused to acknowledge his presence, which he thought was pretty dehumanizing. He felt pretty devalued at that point. But I really think that if you dig down in the basis of those kinds of things, is that's really kind of where we're at status-wise in terms of how the system functions. Even though we have all these successes, and even though we can pull in 400 or 500 people to a state conference with tons of people actually working, helping the system not look quite as bad as it already is, that you have a fundamental level of disrespect that exists. It goes along with the stigma, goes along with the deficit-based models. It really doesn't know how to, this kind of goes to what Mike said, that it doesn't know how to respond to the actual advantages of having people that can actually engage their clients rather than just direct them. Because the medical model that is current use, the hospital drugs and counseling model, really doesn't do much most of the time unless there is some kind of relationship. And most of the relationships that I've actually seen happen at much lower, much more outreach-based levels than happen in 1-hour sessions every week or every month. So anyways, that's all. By the way, since we're running about an hour and a half into our panel discussion or open discussion, I wanted to kind of refocus people around trying to point towards things with the system that have caused this to be true. I think that's kind of where what I was talking about was directed, as well as things that could cure this, because I think really we're becoming more and more politically aware, more politically active, and thanks to people like Kevin and a few others, we have a visibility that we haven't had in a while. And as MHAO succeeds more, we have some leverage to have meaningful discussions about how our community actually impacts the medical model community. So, and how it fixes some of these problems that have been brought up. I've got in the chats, I've got a good 3 pages of people's responses about ugly, awful things that have happened, either while they were peer supporters having to do something, or just simply happened to friends. And I'm sure that's just the tip of the iceberg. And personally, I don't think anybody that does this with any conscience or ethics at all really wants any part of that. And we've accepted that for a long time as a trade-off for being accepted in a minor way within the system's payment schedule. So anyways, if people have ideas of what causes and answers, this would be a good time to start that discussion for the last half hour. Not everybody raise their hand at once, please.
Am I up next? I want to make sure I'm right in line. I don't want to
I think you are.
skip over anybody. Okay. So been listening to everybody's stories and all of the stuff. I'm assuming that what is mostly being talked about is peer workers that are employed by treatment facilities, whether that's a hospital or a clinic or something else. And then there have been some other methods isn't the right word. It's getting late in the day. Models, not really methods, but I guess other models have been mentioned too. And I wanted to talk a little about how we've created peer services in Clackamas, and it's not perfect, believe me. There are still battles being fought every day when I do my work, and but I have more and more allies also around me since I've been in this county doing this for so long. But I mean, we've created a system that is just peer support. You don't have to go to a clinic and ask for treatment services to get a peer. You can just go, you can just request peer support and you can have peer support. You don't even have to have a diagnosis to get peer support. We have those type of peer support opportunities available. And then we also have peer supports where we have peers embedded with like our crisis services and mobile crisis and at our county clinics and the jail, I don't know, other places. And so we have that available too, but it's more because I wanted to create something that you could access it no matter what was going on for you. And if you want to go to the outpatient clinic and get treatment services there, you can have a peer while you do that. If you don't want treatment at all, you just want to work with a peer, you can do that too. And if you were in treatment 2 years ago, things have been going great, hitting a rough patch, you can access just a peer to get through that rough patch if that's what you want to do. And often you can call that same number you had 2 years ago and you will likely get the same peer you had 2 years ago because they tend to stick around here. And all of this is done contractually. Even the peers that work in clinics and in clinical settings are contracts with peer-run organizations because the value of that peer support is so important, or that peer supervision, sorry. So you're not just stuck in this clinical space getting pressured by clinical people wanting you to do things a certain way and not getting the support of coworkers that are also peers and supervision that is coming from a peer. And don't get me wrong, it's like I said, it's not perfect. We've got issues here, and we still need to figure it out. But why not create that system that is independent of treatment systems? That's part of what we've done here at Clackamas. I get frustrated because I'm like, why, when I talk to other counties or CCOs or whatever, I'm like, why aren't you doing this? Well, we can't use Medicaid money that way. Yes, you can. We pay almost every single one of our contractors with Medicaid money. I don't know why people can't wrap their head around that. And they're not billing Medicaid. We pay for FTE. So I don't know. I don't know that that's the total solution, but as far as anybody working at the system level and trying to change systems, I'd like to hear some experiences around that and what has worked and what hasn't worked. What are the nightmares, but what are the good things too? Are we that big of an anomaly? I mean, it's possible.
Andrew, you might want to speak to this. You had your hand up.
Thank you. I would care to say things. I don't like to just wrap on because I got taught 50 years thinking about it. It all comes together to me like a song. And again, I think the Social Accountability Work Group, including Drake, have a lot to say. But what we need to do is a whole work process that changes how things happen in a deep kind of way. And that's what Drake does every day to build that. And many people here also. So, and I basically have got organizing the psychologists so that the various psychologists who really want to change things are starting to work together more. That's my particular personal project. But change is needed, and we have to find a way to work the change. And thank you so much for all this excellent conversation. And I shouldn't take up all the space, but come and look at our work group and see what you can do from there. And even the parts of myself and Drake and Delphine and also Lynn Stewart have put up there. Anyway, thank you.
So I don't know if we're going. I have my hand up, but nobody. So I'm going to just
Go
speak
ahead.
real fast in response to Allie's question.
Jessica stepped away, so I'll moderate. Go ahead.
So once upon a time, not so long ago, those of us in peer recovery services used to do the training that we were talking about during new employee orientation. It was short, it was a one-off, but it was an opportunity to speak to all of the new staff that were coming into Oregon State Hospital to work. And a consistent consequence of that was I would receive phone calls, emails, and drop-ins from people working across the hospital asking for assistance. They could be a psychiatrist, psychologist, a social worker. I had people from our food and nutrition services, environmental services come to me because they had family members that were experiencing crises, or they had children who were experiencing suicidal ideation. And so they said, you know, we were touched by the information you shared. You sound like you know what the hell you're talking about. Can you be helpful? So we know it works. And people will respond. I mean, that's the one thing at the end of the day that I have seen almost always works. Somebody put this in the chat, I don't know, like a million comments ago, but they said about the ego. you will occasionally, or I will occasionally run into a clinician, another staff person whose ego is so huge, they could give a damn about if you can be helpful or not. But at the end of the day, with most of the people that I have worked with, if what you do is helpful, they don't care who you are. Please come in and be helpful. That's what they want. And so the more that we can be out there and we can be present and we can be connecting and creating these relationships and demonstrating the value that we bring, that can radically change the system. And I wrote just in the chat, just so people know, they eliminated our presentation from new employee orientation. They claimed that it was to streamline the process. And so that is no longer an avenue to be able to have a broad impact on people who are just coming in, who haven't been trained in how we operate here. So, but it's possible.
So glad you're here. Thank you, Malcolm.
Thank you, Luke.
Other good answers people have, other good ideas, other analysis of the root causes that could be gotten at?
I think I see Katie and Andrew with their hands up.
One. Okay, can you hear me? So I'm wondering, I think it would be really cool because I keep hearing the conversation about medication and how do we support people either take it or not take it. And I think a piece that's missing, at least from the system that I work in, is we don't allow people to be in an extreme state, a full extreme state. We allow people if they're kind of in an extreme state, but still compliant and willing to take medication to get through it. But if there's an individual who is absolutely against medication for good reason, you know, they've been on it a long time and they're having all these side effects, and they're at a place in their life where they would like to go off medication and have their team support them do that. At least in my system, we're not ready for that, or we don't understand that, or we don't agree with that. And so that person is left to go off the medication on their own with no more support, and left to go back into a higher level of care, or homelessness, or all these other systems, when they were in a system with a team that says, oh, now that you're not following or being compliant, we're gonna let you go. And essentially, so I would be curious about how do we advocate that as a system as a whole, because I know it's everywhere. And then to touch base on Allie, the most work I do is with people who are not in the system. So my whole goal is to work with people in the community and connect them with the resources or treatment services, whatever you want to call it, that will work for them. And that has been very beneficial for people to be able to have the peer support without ever walking into a clinic. I've even had people not even use their real name, and we were able to meet them where they're at in the community. And that's a huge piece of this movement, and being able to meet people where they're at. And so just encouraging others to be able to follow that same model, I think is really important in this peer movement.
Thank you, Katie. I think we have Andrew, who's next.
So some of my thoughts are, as far as some of the root cause, I think a lot of clinicians and psychiatrists, they feel a need to be validated still. And I think they feel threatened if I think just peers existing is a sort of threat to their status because we're essentially invalidating their worldview that mental health issues are an illness that originate in the brain. So we need psychiatrists and we need drugs to fix that. We need a therapist who can do CBT on us to fix that. And I mean, they've invested so much in doing what they did, you know, to get the doctorate degree or master's. They have a lot of emotions invested in that. And I think if we can find a way to approach it in a way that's still validating for them, and I don't know how, but if we could do that, I think it could facilitate a conversation where they might be willing to hear more of our side. And I love the idea of like going into schools and offering classes or even like a workshop to students. I think I wish we could have conversations like this with the broader mental health community, with clinicians, therapists, psychiatrists, as well as peers and participants who feel they're benefiting from the system. Because that's another thing too. There are two sides. One side feels like, oh, the system's meeting my needs. I need to be on meds. I need to do this and that. And for them, nothing else works. And for some of us, we consider ourselves survivors where that did more harm to us than good. So I think we even need to bridge that conversation. But yeah, just some thoughts.
Thank you, Andrew. So we're just about 15 minutes to go. Let's see if we can fit these next people in. I see Kevin, Roberto, Michael, and Juliana. So we'll start with Kevin.
Before Kevin speaks, could I mention one thing that in the chat is a link to OCSC's website. And it's in the last few.
It's tinyurl.com/OCSC lists. That's the shortcut. It's OCSC's website is called unitedvoiceforchange.org. And we have a bunch of mailing lists, OCSC's mailing list, as well as some others that are specific to peer legislative action and rule regulation, those kinds of things. So there's a lot of information on that page for each of those groups, how to join them. Plus there's also Facebook, social media groups that people are welcome to join. We have a lot of discussion and posts there. So either through email lists and or through Facebook, everybody's welcome.
So unitedvoiceforchange.org.
Unitedvoiceforchange.org is the website of OCSC, but we created a shortcut, tinyurl.com/OCSC lists will get you all the information for those different lists.
Okay. Thank you. Kevin?
Oh yeah, this is Kevin. I'll just cut it short. I'm doing a workshop on Thursday about politics and mental health funding. But one thing I wanted to say is I have abandoned the hope or the opportunity to completely reform or revolutionize the entire mental health system. I work on specific, distinct, particular projects, which I think are going to be, hopefully, if funded and supported, will become a useful model and up against the dominant allopathic system, which I think fails people, i.e. what we and a bunch of us in Oregon have been working on, peer respite, a non-clinical model for people in psychiatric crisis. And then I also want to say I'm an individual who spent half of my adult life in extreme states, what my ex-psychiatrist used to call, psychosis. My experience is beyond just having what he called psychosis. It's also living in poverty, being discriminated against as a health consumer by my primary care, I think even if you don't identify as a peer of going through the same experience, there is something to be said about a non-hierarchical, a person who does not have the power to lock you up, take away your kids, force you to take horse pills, and hopefully be a support person on a positive journey forward. I have a lot of friends who are psychotherapists who really, really support the choice and the voice of the mental health consumers they see and help direct that in a way that's most informed, follows the latest science, and also is an act of compassion. And so I don't think this is only about peers, but I do think that there is a system that does not want to hear the things that we talk about, particularly that our system of care traumatizes the people that they profess to help. And I think that's very important to recognize. Thank you.
Thanks, Kevin.
Is it my turn to talk, or? Well, I want to say one thing. There are many potential allies within the system as we know it. Many clinicians, even doctors, psychiatrists, as potential allies. We have one dedicated, true enemy, and that's the psychopharmaceutical industry complex, I call it. They are out for the money. There are many people working within that industry that believe that they're helping the people who run the shows there. They're just out for the money, and they will do what they can to stop us. So just to let you know about that one, and I've experienced that directly. They tried to censor me. So anyway, that's what I have.
Okay, I think I may be up next. Hopefully you can hear me. This is Juliana Sellers. I'm with Poetry for Personal Power. I have loved this whole discussion, but one thing that I haven't heard mentioned is a practice that we've been doing as an organization for the last few years, and it's called story circles. And basically it's an opportunity to bring together peers and providers and peer support specialists in a basically peer support group where we just hear people tell their stories of lived experience with creating wellness. And what it does is it humanizes, it puts everyone on the same plane. There isn't someone who's in charge of the group who has all the power, even though there are facilitators that keep it running smoothly. We use the practice of a talking stick. We take turns listening and really hearing each other deeply. And it's just this process of humanization, of hearing the trauma that even mental health providers go through. And our premise is basically that if you have a mind, you need mental wellness, and trying to teach people that, really just being human together and connection and supporting one another is a really powerful way to build communities of wellness. So I just wanted to put that out there. I'll drop my email and our website in the chat, and we'll go from there. But yeah, we have story circles twice a month, and we're working on trying to bring both peers and providers and anyone who's interested in working on their wellness together into those story circles. So thank you.
At this point, I would like to ask if anybody that hasn't been heard would like to speak. Please go ahead and feel free. Let her rip. If you felt sequestered or shut out of the conversation, any topic. We have 91 people here, which is a small village. Thank you for everybody that's posted in the chats. A bunch of stuff that was put in there is actually really helpful and does a lot of that extra work here. So.
Did you say
Right.
any topic, Drake?
Except pro football.
Okay,
Oregon does
okay.
not have a pro football team.
All right. There is one thing that weighs heavily on me when I'm working and trying to figure out how to continue to make this work, and how to expand it is, and I think, well, most people who know me in this room know I'm against billing Medicaid for peer-delivered services. What scares me is that the state is moving in that direction, and it will make peer supports that are being paid for, like in Clackamas through contracts, it will make those programs very vulnerable fiscally, as the state moves towards that. And I don't know what to do about it. I'm not sure how to make it better. I'm not sure. So if anybody who knows Medicaid funding and how the CCOs do all that stuff, and I think part of the problem is we don't have enough people left in Oregon that are in power that remember why CCOs were created, why we created the waivers. It was to create more ways to flexibly spend Medicaid. That's how we got a lot of things started in Clackamas. And I worry that we're going backwards, and we're going to lose that flexibility, which is going to put everything we've built in Clackamas at risk. So anybody has, bright ideas, I'm way open to that right now.
If you could contact me off list, Ali, I would appreciate it.
Okay, thanks, Drake.
Same here, Ali.
I do have to warn you, though, I went to a conference once with somebody from a Coos Bay drop-in center who suffered from horrible insomnia. And she asked me how to explain how to get her beer drop-in center to bill Medicaid. She was leaning up against the bedstead while I was sitting at the table in her hotel room. And within 10 minutes of trying to make that explanation happen, she was snoring.
I was going to say, she went right to sleep, didn't she, Drake?
That's not a joke. So,
I have insomnia, Drake. Can you make me a recording of you explaining that?
I probably already recited in my sleep, so I will leave a machine on during the night.
Me too.
Hey, Jake, this is Luke. I thought you might like to know that there's the causes and there's the solutions, and you've probably already considered we can learn from other areas, other regions, coalitions, associations, alliances that have it's been working for. So I've got good reception with the Western Massachusetts folks that some limited technical assistance can be provided to help build something similar over here to service in the Northwest. And as far as I know, please let me know, people, if you have heard differently. Santa Maria Recovery Learning Community, Western Massachusetts, and Northwestern and Southern Recovery Learning Communities, and the one in England, they are well regarded by the community, both professional, clinical, governmental, and peer alike, as being respectable experts of the topic. I think we can do something like that similarly here. Together with you, all your pieces, bring us together. We can do it. That's what an alliance is. You said allies, didn't you, Ally? Ally. I love your name.
Juliana, you had your hand up.
I did. I just forgot to take it down, but I'm excited. We're actually based in the Midwest. So I'm in Missouri. We're working with Kansas, Oklahoma, and Colorado, but I'm interested in building these networks and, keeping this going nationwide, because this movement isn't limited to any particular region.
Okay, so, Milkweed Alliance in Wisconsin, very close to you, Juliana.
Milkweed? Okay,
yep.
Great.
There you go.
Thank you so much. I'll have to look them up.
I have a quick question. Can the chat be saved and sent out to all participants?
It can, yes. It'll come in notepad form.
I would love it if that were to happen.
One of the hosts needs to save it.
You can also save it yourself in your little chat box window, if you press file.
I am aware of that.
Great.
My computer doesn't work so well. I need to get my workplace one, and I cannot save it.
And people on phones don't have that option. So, so I just, I want to echo, if people haven't had a chance to access Western Mass or Wildflower Alliance, they do just wonderful, wonderful work and put out so much amazing material. I actually, whenever, I mean, unless something makes it so I can't, I attend a monthly meeting they hold for peers who work in coercive and restrictive settings. And it has saved me at times when I have been feeling like I just can't keep doing this anymore. Being able to talk to others who are in the same type of situation, and they actually work contracted. So they're with a group where they're getting all the love, and then they go to the places and don't get the love, and they come back and get the love. And still, it's really challenging for them. But the other thing I wanted to mention is when we're thinking about, you know, what's not working in our system here, you know, I'm no more important than anyone. I mean, that shouldn't have to be said, but I'm saying it because I've had a lot of different roles. I've been a former chair of the Oregon Consumer Advisory Council. I've served on multiple committees. I've worked as a professional consultant with the National Center for Trauma Informed Care, where I traveled around the country doing trauma trainings for all different sizes of organizations. And I sent a series of emails over the last, Allie, you might be able to help me, maybe month or 2 months, requesting that the traditional health worker leaders consider extending the time that people need to renew their certification because of the COVID year. And multiple people have talked about how difficult it has been to access different training. And I have not even received the courtesy of a response. I mean, they didn't even send me a little emoji flipping me off, just nothing. I'm just getting silence. And to me, that is such a canary in the coal mine of the absolute disrespect that the state has for who we are and what we do. So I just wanted people who would care to listen to me kvetch about that. Thank you.
I think, folks, that about does it. Thank you, everyone, for being here. Thank you for your participation. Thank you for not rushing the microphone. Everything that made this thing go really well. Thanks for your time. Jessica, is there something people need to know about this session? Is it eligible for CEUs or stuff like that? Or I noticed people have requested the chat feed, and we'll try to get that to people, but I think that the MHAO has the email addresses of everybody. So.
Yep, I just took down the names of the people who put their information on the chat box.
Okay.
Surveys will be sent. I don't know if it's been sent already, or maybe it'll be at the end of your apocalypse to get your input on presentations like this one tonight. So thank you, everyone. Without you, we wouldn't be here.
Right. If it's like last year, a form will be sent out with the list of workshops that you participated in. That's how you fill it out, sign it back. It's all electronic. And that's how you get your CEUs.
Okay.
Thank you so much, Drake. Good night, everyone.
Does anybody know if we didn't get the form to track this, where we would find that?
Jessica can speak it.
What do you mean? What form?
I thought someone said for the CEUs.
Oh, the committee should send it to you at the end of your apocalypse. So they go by what classes you registered for, and then they'll send it to you. So you won't get anything right away. It'll just be after.
Okay, thank you.
Okay. Thank you.
Thank you. Recording of this, if we missed the first part, how do we access the recording of this?
You know, I'm not sure about that. I did see your question on there, BJ, so I will need to get back to you on that. I'll shoot you. Yeah.
Okay. we're down to less people than we need to field the baseball team.
Okay, I think I got everybody's email. Great. Thank you, everyone. Have a good night.
All right, thank you, Jessica.
Thank you.